Good morning. It is the first time in 2 years you are not required to wear a mask indoors or outdoors since the pandemic began. While COVID is still in the air, so are other viruses, along with other stuff in the air, all of which can make you sick or make it tough to breathe while just trying to enjoy some time outside. A live look right now at KCI from our Scout cam right there, where the mandate to wear face masks on airplanes and in airports has now been extended until early May. That has many of us asking how the air filtration systems will work to stop the spread of COVID and other viruses while on board. The morning medical update starts right now. It is Monday. Hope everyone had a great weekend. It's April 18th. Thank you so much for joining us here on Facebook, on YouTube, and on Twitter. Just a quick reminder, tax day is here. Big buzzkill for the Monday, right? Okay. What a great way to start out the week. At 8:25, trying to get healthy during the pandemic took a drastic turn for those trying to quit smoking. The results to a new study may not surprise you. At 8:15, Dr. Dana Hawkinson will give us the latest COVID count coming out of the weekend. We'll catch up with him in just a moment. But first, what is in the air? We already know COVID isn't going anywhere, nor are other viruses like colds and flu. And what about pollen and air pollution? Our expert has the answers. So make sure, get your questions sent in to us right now on YouTube, Facebook, Twitter, and the Medical News Network. You'll find links to those right there on your screen. A live look at downtown Kansas City, again from our scout cams. Are you among the growing number of people like us sniffling and sneezing when you wake up? You can't blame it all on COVID now, but losing the masks could be partly to blame, as we are now exposed to all kinds of viruses and stuff and springtime pollen that is in the air. Dr. Bill Barkman is joining us. He's a pulmonologist and critical care specialist here at the health system, joining us along with Dr. Steve Stites, our chief medical officer, but also a buddy of Dr. Barkman's. He's also a pulmonologist. How are you guys doing today? Good.
Fine.
Good. You guys have a nice Easter weekend?
We did.
Relaxing?
Yeah, a little wet, a little cold.
Yeah.
Typical Easter.
Typical Easter and springtime around here, I know. Well, something affecting a lot of us these days, allergies. So why does it seem like our allergies are bothering us more than it has in the past? Is it just, we always say this is the worst allergy season, guys, but just talk to us what to expect. What do you think we're going to expect this year when it comes to that and how we're going to handle it?
Well, it's a little hard to predict, but it's been pretty dry until we've gotten some recent rain, and that tends to mean that we're going to have more particles in the air. And the pollen is anywhere from size from about 3 micron to 100, and obviously the 3 you can't see. So basically, as the pollen comes out and the dust in the air, if you notice recently, if your car was outside, there'd be dirt on it after, well, the dust's in the air. And combination of that really drives it, the symptoms. And most of the allergy is really histamine related. The lung only has so many ways to respond to these things that we inhale. And so that's what you're going to see, the congestion, the stuffiness. You take your antihistamine, you take your inhaled steroid, and it helps all of that. Again, there is some science to suggest that viruses, if you've had a recent viral infection, it might put you at greater risk to having an effect from the pollen, because your airway is affected by the virus, and so then the pollen can get deeper into the lung and into the tissues.
So how does this affect both of your patients, and how has having masks on the last couple of years helped, and what are they going to now expect now that they're coming off?
Well, I think it's a good question. So masks help prevent infection. We know that we've said that 1,000 times in here. We're going to talk about that more when we talk about where we are with COVID in a little bit. But masks have come off a lot, well, really outside for a long time, and inside more recently. But I think I think the fact that we haven't had masks on the outside, Bill. And by the way, Dr. Barkman is also an expert in occupational medicine, occupational health. So he's got another title that he carries, which is germane to this, because we talk a little bit about indoor air pollution. But on the outside, with the pollen rise, I mean, it starts in March, really. The pollen starts blooming. If you follow your little weather reports, you get the little alerts, high pollen day. It's like every day is a high pollen day right now. And to Bill's point, the rains come, everything blooms, and pretty soon people are sneezing and wheezing. And the sneeze and wheezing thing, I don't know that, because we don't mask outdoors, I don't know that that's really changed anything. Right. I think the fact, historically when we masked outdoors and indoors, but we didn't mask outdoors for very long, it may have made a little bit of difference. But the reality is the sneeze and wheezing caused by all the allergens in the air man, that's largely an outdoor thing, and people haven't had masks on, Dr. Barkman, for a long time outside.
Correct. I mean, people just live with it. And because it's seasonal, you the spring, the fall, and then, well, I don't have to worry about it. Or they start taking medications and they can live with it for the short period of time. Viruses, again, interesting, as you point out, masks have come off. I've got a patient last week who just had influenza. I mean, again, that late in the game. Normally we wouldn't be thinking of influenza this time of year. And influenza A. Again, he doesn't wear a mask, and he's outside. And his girlfriend got it and passed it on to him. And so again, the viruses are still with us, and it's clear that when we were all masked and cloistered down, we didn't see these viruses. They went away. Look in the pediatric side. We didn't see RSV.
Yeah, we didn't see any RSV for a while.
We didn't see them at all. So clearly the masks work. Not so much, you're right, for the allergy piece of it. We end up just treating by avoidance or medication to take care of those symptoms.
We've had a prolonged influenza year this year, and Hawkeye can comment too, and it continues to go along. We're still seeing a small number of cases, and I think the other thing is the influenza vaccine. A, it's late, so you're going to be losing what effectiveness you had, but B, it wasn't very effective this year. It had a 16% effectiveness, Hawkeye, so influenza vaccine kind of missed this year. Just to point out, the COVID vaccines are still 75 to 95% effective. Remember what a home run that is, people. We got to keep that in perspective because the influenza vaccine wasn't all that effective this year.
Yeah, and I think the other issue is, we had seen an increase in influenza. It decreased in January, early February, but from mid-February to March, there was certainly an increase in circulation of the virus as well. So, is that due to lack of very good effectiveness of the vaccine, but also the other mitigation strategies which were not really being followed, such as masking and doing all those public health things to help reduce overall circulation of viruses.
So you both mentioned it, how these factors affect lungs, but just help us understand it a little bit more. And I have a personal reason why, but just about the environmental factors. My daughter has really bad allergies, and so of course I took her to an allergist, not a pulmonologist. You take her to an allergist. I thought she was going to have some magic pill that said, great, here you go, they're gone. And it was like, nope, you got allergies. And we did the back prick where, and yep, she was allergic to this, and that. And it really was just doing your own home remedies, wiping down the pets and changing sheets and washing hair at the end of the day. So that was really surprising that there was no magic solution. It's just like you said, you have to just take the pills and get through the season. But when things like that go when you're not taking care of it, can it ultimately affect lungs? Is there anything that will go from an allergy issue into a lung issue?
And Deborah, we'll talk about this, that allergies can definitely affect the lung. They do it mostly in the form of asthma or allergic and reactive airway disease. And when that happens, you can begin to get tightness in your lungs and have more and more of it's like breathing through a straw. And so, people with significant allergies often can develop asthma, sneezing, and wheezing. And it's the wheezing part you really want to avoid because, Dr. Barkman, we know that prolonged exposure to allergies untreated with asthma can lead to chronic lung disease.
Correct.
All right, talk to me more about that because now I'm a concerned mom.
You're a concerned mom.
I'm a concerned mom.
Okay, so I mean, asthma. There's an irritant form and there's an allergic form, and he's talking about the allergic form. And again, what happens is the body reacts to the compound it's allergic to. And if you develop asthma, you have to monitor it appropriately, see a pulmonologist or allergist to be sure that you maintain your normal lung function with your medication. Because if you don't treat it appropriately, it can become a chronic and fixed disease, and it'll affect your lifestyle. So again, unfortunately, if you develop allergic asthma, it takes a lot more attention to detail. But again, hopefully it's related to one season, maybe the spring, maybe the fall, maybe the winter. And that's what you go to an allergist and sort that out so you can avoid what you can, and what you can't, you treat appropriately and be followed so your asthma doesn't turn into a fixed disease versus a treatable disease.
And I think the key here is that fixed part. So there are drugs, and for your daughter, if she develops signs or symptoms of asthma, then normally what happens is you start having shortness of breath. You may just have cough, you may have a little bit more mucus production, and you may find that you have a little bit more trouble with exercise. And that's when you go to say, okay, to your allergist or your pediatric pulmonologist, and you talk to them and say, what do we need to do around that? Or is it older with one of us? And the key is that early and effective therapy for people who have allergic based asthma, there is really good treatment for that, and we can usually prevent progression. And those things are either inhalers. There are some pills you can take, and there are even some injectable medications you can have. But what you really want to do is prevent that disease, which may make your airway mad, and it goes into spasm, from having that spasm because of inflammation and just ongoing irritation of the airway. You want to prevent that spasm from becoming a fixed, narrower tube that makes it harder to breathe through. And again, that's all very addressable, but you got to make sure you're getting the right, you got to make sure you're paying attention to it.
And one other thing in the pediatric side, some people outgrow their allergies. We don't understand this. I mean, they may be born and develop allergies within the first year of life, but then as they grow older, that goes away until some trigger, again, as an adult, maybe a respiratory infection or whatever, sets it all off. So in the pediatric side, not all of them go on to have a chronic illness with it. It just depends, and we don't know how to predict who that will be.
And then there's a second peak of this sort of allergic asthma later in life, and you're like, wait a minute, I'm supposed to be done with all that stuff.
Right.
Who said this was okay? This was not okay. and people, and it comes back. The other point is that these viruses and allergic disease do interact sometimes. If you get a viral illness, it can sort of it sort of ticks off your airway, if you will. And your airway is really kind of mad and gets a little angry, and then the allergen comes in and just really wreaks havoc. And so those things can sometimes go hand in glove.
Right, exactly.
I love it when our show turns into free medical advice for me.
Well, there you go. Well, that's why we're here, Jess.
That's exactly why we're here. That's why we're going to ask questions in the audience.
If Sonny says needs a little help, we're here to help.
That you are here. Okay,
We're here to
thank you. Thank you for that. We're going to move on to talk about the lung gala here in just a little bit. But just before we do that, Dr. Barkman, just like what's the one main thing that you worry about with patients this time of year, and what advice do you give them?
Well, this time of year, we're going into the allergy season. And so if they know that spring allergies bother them, they need to get on their medicines prophylactically, either the inhaled steroids, or they can start taking their antihistamines orally, and stay on them and stay persistent with them. And when it really gets bad, stay inside. I mean, we're going to see when the oaks come out here pretty soon, everything's going to turn green. And in those particular cases, if you're out and about, you probably should wear a mask. There's no science to support that, but I do believe that it does help because it's going to cut down. Just like if you have allergies and you've been outside, the allergists say done for the evening, you should take a shower, get rid of the clothes so you don't go to bed with the allergens on you. And so it's common sense kind of things to cut down your exposure.
I think it's great now with masks in our lives. You know, when people used to wear masks this time of year, you think, well, that's kind of weird. And now it's like, that's just the thing to do. We are getting so many questions, so we're going to get to community questions in just a bit. But from the ground to the skies now, at least through May 3rd, you're still required to wear a mask on airplanes or in the airport. So many folks are wondering just how do the air filtration systems work to stop the spread of COVID and other viruses on flights? What's your insight, Dr. Barkman? How does it all work? Not that you work for the airlines, but what can you tell us about these high-tech filtration systems?
Well, I think that the airlines have stepped up, and the newer planes especially have HEPA filters that recirculate the air compared to the older days where the indoor air quality in the plane was not that good. So I think the industry has stepped up. Their HEPA filters, again, those are used throughout the hospital, probably used in the ORs, and other to the best we can to cut down on particulates, whether it be virus, allergies, etc. And so it's encouraging. And then the mask on top of that, I think it really does make air travel reasonably safe. Again, you're crowded a bit. And so from a virus standpoint, still wearing eye protection is also probably a good thing. and we'll go from there. But I think the airline industry really has stepped up. And again, you don't have that HEPA virus at home, a HEPA filter virus at home to really clean the air. So
something's working because schools, everybody was required to mask, not a ton of outbreaks until they started coming off again. So what are your thoughts? I mean, they work, no doubt,
I think
right?
the masking works, and I think airlines have done a great job. The key in the airline, the graphic was showing it. The air comes out in one direction, and then it goes back down to the floor, and so the air is moving. If you sit on a plane, you can feel the air movement. It's like when you sit here in the studio, you can feel the air movement. You can feel the air moving in the plane. And before, it wasn't like that as much. And so they really have done a better job of creating a safer environment on air travel. So I think what we haven't challenged yet is the high transmissibility of this virus with masks off and that new airflow technique in planes. That'll be the real question, is what happens when masks come off on airplanes. With masks on and the negative airflow, the airflow pattern on airplanes, it really looks very, very safe. But when we take the masks off, when there's a high level of disease transmission, I think we're just have to wait and see how that goes. To your point about schools, et cetera, it's all about community rate of transmission. Community rate's down. But if you look around the country right now, that's not true. If we follow that heat map, you look in Colorado and you look in New York, especially central New York, the rate of disease transmission now in central New York is as high as it was in the Delta variant last November. It's really re-escalated, and it's just this thing. We've seen it again and again. Wave, wave, wave. The question now for us is, will hospitalizations follow the wave? And we don't know that yet.
I'm going to check on some community questions right now. So start setting yours in, but let me get to one real quick. Well, first of all, Deb has not a question, a comment. She is loving the facial hair.
Hey, there you go. And listen, shave to save. Throw the QR code back up there sometime today.
We will.
It all comes off. May the 6th, a fundraiser for Hope Lodge. I'm one of the shavees, Gloria Solis, one of our outstanding physician or female leaders down in the cancer center is also. She has a lot more hair to lose than I do. So hats off to Gloria. But the shave thing, we'll see. It may come back. We'll see.
All right, Deb also has a question. Does COPD and asthma go hand in hand?
No, not necessarily.
Okay.
And COPD is a very loose term that has a whole lot of diseases thrown into it. Asthma is a little bit of a loose term, not quite as many diseases go into it. Asthma can be construed as a form of chronic obstructive lung disease. What it means is if you have an airway that narrows, that becomes an obstruction. Imagine if you're trying to blow through a straw as it blows through a big pipe. That obstruction can become chronic and fixed. You don't want asthma to do that. That's why we recommend such early treatment. But Bill, people often do that. Usually when we talk about COPD in a lay term, we're talking about chronic bronchitis, emphysema, smokers, things of that nature.
Right.
Asthma may stand apart from that. It can't, but it depends on whether you're a lumper or a splitter.
Right. And in fact, now we're starting to see, as you were mentioning earlier, some of the eosinophilic asthma coming back. We're starting to see overlap syndrome where they have both.
Yeah.
And we know they have both because imaging shows they've got emphysema, they're obstructed, some of it's reversible, and so at least they can get symptom relief with that.
And a lot of them, the ones who are this overlap, a lot of them are smokers.
Right.
We're going to talk smoking here in a
Or
minute.
vapors. Don't
Tanya
do that either.
wants to know, she says, I have a doubt, but do masks protect you also against pollution too? The pollution in the air.
It depends on the pollution. Mm-hmm. I mean, there's particulate pollution, which would be helpful, but not some of the gaseous sorts of compounds. The mask is not going to help there. So it depends. Again, what you're exposed to.
And it depends on the mask, right? An N95 mask goes a whole lot further, or a KN95 can go a whole lot further. That's why 95%, 99% of particles are filtered in a standard fit mask, like the ones I wore down here, 80 or 85%. And so it's a big deal. And how well it fits.
And in industry, where they have exposures to chemicals that they need, they have specific masks with specific filters for those chemicals. And generally, you can't buy those at, say, the hardware store. Mm-hmm. You can get the N95s that'll help with the particulates, but not necessarily the chemicals.
Right, so there's different factors.
Right, different factors.
And when you saw that graphic up there, the guy changing the filters in the airplane, remember that? He had on a hazmat. He had the hazardous material suit, and that's to protect against all sorts of airborne problems.
Now, where do we get those?
Yeah, you don't. It's a good look. Covers up the facial.
Good look. It's a good look. Okay, Lindell, another quick question before we move on. Do air purifiers help with these allergies? And just, do you recommend those for your patients to have in their homes?
Not routinely, but in some particular cases, they may be helpful, if, especially if you put them in, say, the bedroom at night, where most people spend their time. Now, with people working at home and all, perhaps in their office. So they do help some people, but you can't predict on the front end whether they're going to be helpful. But you can also get HEPA filters as well as those air cleaners.
Do you recommend them for your patients? Or?
I say exactly what Dr. Barkman just said, maybe because he helped teach me, but for some people it may be helpful, but not for all people in general. And it's very much depends on the individual circumstance, how good of ventilation that home has, whether you have other problems in the home, like, and I don't want to get too much into this, but fungal or other radon or other things that may be causing trouble. And then you sit back, you have to do a full home evaluation, Dr.
Right.
Barkman, and then you make a decision.
Right.
Well, that's a good question, though, because I think it applies to all of us. The
It
cleaner
does.
the air, the better. That's what I would be thinking as
Well,
a consumer at home.
And you can do all that stuff you want on those filters. Homes don't have the air exchange that a building like this room does. So how many times does your air turn over in your house? Not relatively infrequently. And so even if you have the filter, unless you're moving the air through a long time, the particles get suspended in the air for a while, then you breathe them. Here, with the negative airflow in this room or in some of our hospital rooms, the air is moving around a lot and the air changes over, and like the turnover rate may be 6 or 8 times an hour. In homes, the turnover rates may be once a day or 2 times a day. I mean, it's
Less.
harder.
Yeah, it's clearly
It's a lot
less.
less.
Except, perhaps when the air conditioner's on and
Right.
running
Yeah.
more constantly. Yeah.
Right. Then you're always wondering what's coming out of those vents. So,
Yeah.
Okay, let's turn to Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Let's talk a little COVID today. What can you tell us about our COVID count? Good morning.
Yeah, well, I also think it's probably important to change your filter in your home AC unit as well. So right now, our COVID count here at the health system, 4 active infections, 2 in the ICU, 0 on the ventilator, 17 in that recovery period. Again, we are happy that our active infections are in the single digits. Obviously, less is better. So we'll continue to watch the number of cases. Just as Dr. Stites said, I think overall in the nation there's been a slight increase in the number of cases, but hopefully in the next week to 10 days to 12 days, that will not constitute an increase in hospitalizations.
I think that's going to be the key. We've said for a long time there wasn't an increase in hospitalizations in Europe from the Omicron BA2 variant. There is a little bit of a bump, not like we saw with BA1 and not like we saw with the Delta variant. But again, coming back to the information coming out of Central New York, where it's the BA2.12 or the BA2.2 variant, 2 different types, which appear to be even 25% more transmissible than the baseline Omicron variant. And what that means is it's easier for the disease to spread. And so in Central New York and some parts of New York City and some parts of the Northeast, but especially Central New York, you're seeing a pretty significant outbreak in terms of the number and the amount of community transmission. The positivity test, the test positivity rate, the fecal wastewater, et cetera, is getting up to the level we saw in the Delta wave. Remember, the Delta wave was last November. So pretty significant. What happens is we tend to be 6 weeks behind that. So I think predictably we're going to start seeing it. The next thing we need to talk about, and that's why there's a headline that we're going to talk about, is the New York Health Commissioner says that they may move to medium COVID level alert. And it's because they're having a lot of disease transmission. They don't know about hospitalization. It takes 4 to 6 weeks to really establish that. And until we see the result of the increased disease transmission, we simply won't know. I think what we have to be on guard against, though, is that we've been pretty comfortable. Masks have come off. We started to debate whether masks should come off in hospital administrative spaces, and then all of a sudden, the number of our employees testing positive and number going out for COVID went up last week. And so I think here it comes. We have to be cognizant of things like that and make good decisions. You don't want to put masks on and off all the time in a hospital. What I think it does mean, though, and you're seeing this in Philadelphia, and you're seeing it kind of heralded in New York. Philadelphia already established a mask mandate again, is you have to learn to pivot. And it's unfortunate, but it is true. You pivot when the numbers rise, try and blunt the effect on hospitals, and then you can pivot back and try and get back to more to remove mask mandates as much as possible. I think the other thing you see that came out of the New York Times is this cause of death. One of the things we've tried to put into a picture form here, and this is from an article in the New York Times this last weekend, is how much death is COVID causing? Is it really that bad, or is it not as bad as influenza? And that's an interesting question. If you look at the waves that have occurred since March of 2020, a couple of them have demonstrated, first of all, heart disease is the biggest killer in the U.S., usually followed by cancer. The COVID topped those for a while, sank back down, got up around heart disease, and now COVID is currently less than heart disease, more than cancer, back with the most recent wave, and this one stopped in January, so we don't have the full Omicron data is not in there, so it's probably going to go back above heart disease again. So COVID really is a killer, and you have to remember that. There's a lot of transmission, but there's still been a lot of death with COVID. What we don't know is in this new wave, this BA2 wave, whether or not the death rates are going to increase, and so we'll have to see. My wife gave me this great gift for Easter. You see it sitting here. It's an Easter egg, right? She made this Easter egg.
She made this.
She made this. She and a buddy, they went out and made Easter eggs for us. Those were our Easter presents, and I haven't got my wife an Easter gift yet. My bad. But you'll notice the little spike proteins
You're
in
the
my
gift
Easter
that keeps
egg.
on giving.
Yeah, I know that there's some unfortunate parts of that. The spike proteins on my Easter egg, on the back it says, hope for the end. Easter is, a very hopeful time for those of us who are the Christian faith, and so hope for the end. But the little spike proteins in the front. Thanks, dear, for making a spiky Easter egg for me.
I love
That's
that.
kind of cute. It's kind of cute.
That.
So there you go. We're going to hope for the end. But in the meantime, we're going to keep an eye on the rise in the numbers, recognizing COVID really does cause a lot of death, and that we look like there's probably another wave coming our way, and what we just don't know is the severity or the extent of that. But community transmission levels as high as they were during the Delta variant in Central New York.
You weren't here last week when news of the new breathalyzer dropped. Just quick thoughts on that.
Yeah, well, I bet Barkman has some thoughts too. I think it's great. I think the future of detection will be rapid detection through means like that, and hopefully, if the early trials of nasal vaccination, nasal spray vaccine work out, that is also a game changer. So we'll see how that goes. But I'm encouraged by the results from the breathalyzer test. It looks really good, about the same as your other home tests do.
Dr. Barkman, how effective could this be?
Well, I think it's important, and it'd be exciting. I mean, it's a quick diagnosis. You can stay home if you're ill. The antivirals, you could take those. So it gives us much more options. And I think we've learned another thing. If you're sick or even having symptoms, you shouldn't be going to work and exposing other people or even other family members at risk. So anything we can do to make an early diagnosis. And now we have antiviral agents too. So I think it just adds to our armamentarium on how we can deal with this disease.
And the good news is that we have actually really effective therapy now for COVID-19. If we get you treated early enough, Paxlovit has a long list of side effects. Got to watch out for that. But the number of treatments we now have for this far outstrip what we have for influenza. I mean, research has made a significant difference here.
Yeah, absolutely. I think, as we've mentioned, the oral therapies, I think those are really good. I would venture to say, Paxlovit right now in the early data is better than even those orals for influenza as well. And I think, again, the main goal is to keep you out of the hospital. Of course, we know that since the monoclonal antibody treatments have come on board, they have really helped to reduce hospitalizations. Now we are having some issues with monoclonal antibody activity against BA2, but I believe there probably will be more monoclonal antibody therapies out there. And as we've seen before, we may be able to go back to using some of the older ones depending on what variants come up and the monoclonal antibody activity towards those. So yeah, I think the outpatient and treatments are better. They are very good, but again, to your point, Steve, it is early diagnosis, so you can get early initiation of therapy in that viral period. It's much more difficult when you get to the hospital and you're more in that inflammatory period.
The other thing just to say was that there was a study terminated early because the drug looked so effective for taking patients who are hospitalized on oxygen. So those who are on a track to have more severe disease, more long-term side effects, and perhaps ICU stay and death. And in those situations, you're seeing that the rate of severe illness was dropped by half. We've not had that level of effective therapy. So the trial was stopped early because it was so successful. They said it's unethical to continue the trial and have a placebo group. So we'll look forward to that one coming.
Yeah, and we've heard, the word game changer thrown around a lot. I think this one potentially could be, because we know that when you get to that stage of needing a higher dose oxygen and you're in that severe stage, it's very difficult to find adequate treatments. Really, the standard of care we had was steroids. We knew the antivirals weren't working once you get to that section of the disease. So I think it is very important, and hopefully we'll see more data, and it can be one of the things that we can use if you are in that severe stage.
Dr. Barkman, let's talk about the 2022 Lung Force Gala.
Yes, that's exciting. It's
Yeah,
coming up
tell us all
on
about it.
May 12th
Okay.
at Children's Mercy Park. The American Lung Association, again, that's one of the fundraisers we have. And of course, the Lung Association's long-standing and for research, advocacy, education. And so that's one of the fundraisers. Again, it's a typical fundraising event. You'll come, there'll be cocktails, there'll be a dinner, there'll be auctions, there'll be entertainment. And the money goes for the treatment, education, advocacy around lung cancer. I mean, a lot of people don't realize that lung cancer is the #1 killer of women. Everybody thinks it's breast, but it's not. It's lung. And men also. And this is worldwide. And the interesting thing is that's coming out over time here is that in the women, probably 20% of them are non-smokers.
Why is that?
Well, we're trying to sort that out. In fact, the International Organization for Cancer Research, Agency for Cancer Research, has named outdoor air pollution as a cause of lung cancer, or I should say association with it. That's gone on for a number of years, and that data comes from worldwide. And certainly pollution in this country is not at the same level as it is worldwide, where biomass burning, et cetera. In this country, of course, we always said smoking. It was a behavioral thing, so the focus wasn't so much, well, you brought it on yourself. Well, with people now non-smoking getting it, well, where else could we get it? Well, in this part of the country, radon's an issue. And you should have your house checked for that. If you don't, well, you should. Because if you've been there a long time and levels are, it's going to increase your risk. And the government says that's the #2 cause. That may change over time. Particulate 2.5 PM measurements, which is what we use to talk about pollution, those levels vary considerably, and the speciation, they're not the same thing. It might be coal dust, it could be just wind-blown dust, etc. But whatever it is, it might be a marker for some of these compounds that could lead to cancer. Now, we all know, for instance, in Kansas, when they burn the prairies, asthma goes up in the people that are affected in that smoke plume. What we don't know is if you do that for years and years and years, will the latency finally catch up and you get a cancer from it? That is very hard to tease out. Mm-hmm. But we know now that smoking is still the #1 cause. If you're a smoker, you're at risk, and now we have trials where, well, actually it's a standard of care where you get CAT scans and you're followed to pick up lesions early, and we've improved mortality associated with that. The other thing with lung cancer research is we've got some new drugs that are immunodrugs that have affect outcome. Prior to all this starting, you had about 15% chance of living 5 years with lung cancer. Now that is improving, but we still need to do more research. So back to why the Lung Association has the Gala. It's our way of raising money to do the research. Now, it's interesting because, again, ALA pivoted a bit, did some research for COVID, and Dr. Brandon Dukoski on the main campus got an ALA grant looking at antibodies with COVID. Money come back locally. The other thing, Dr. Mario Castro has the Airways program here, the ALA established, and he brought it with him when he came. And there's going to be research done there on millennials looking, kind of at them over 20 years to see if they can sort out predictors or where we could find early markers for lung disease. Sort of like the Framingham study did with heart disease. Now, I think it's going to be a lot harder than the heart disease issue because we're not just going to find something in the blood. But who knows? We need to do it because lung disease is an important issue. So, yeah, you should come out that evening. Should be fun. It's going to be on the concourse. And I think the Lung Association still talks about wearing masks, some because we're about lung health. And but it should be a fun evening. And, you know, we've done it for 3 or 4 years now when we restarted sort of Kansas ALA. And the interesting, last year, we did it at a drive-through movie setting because of COVID. And it was a hoot.
Fun.
It was sort of a hybrid. People come out, park in their car, watch a screen, and everything was on the video.
What movie did you watch?
No, we made our own. But and Roy Jensen got an award from the Lung Association last year in that. So it was really an exciting time.
Open to the public?
Open to the
tickets?
public. Tickets $150. Tables $1,500. You can go to the website. Just go in and look Lung Force Gala up. You
got it.
put it in.
Yep, got a QR code right there on your screen.
And it'll tell you if you want to donate something to the auction, if you want to be a sponsor, it's all right there. And so please get in there and look at it and come on out. The other thing we have for raising money for Lung Associations, the air climb. And this used to be down at American Tower, but because of COVID, we had to move that out to Children's Mercy. It'll be in June.
Tell us about that. Air climb?
Yes, air climb. Well, it's again one of those exercise kind of things where you run a course, and it's actually timed. And to see, now there's no, winning to that. The winning is getting your team out there and raising money. Firefighters are often involved in this. And so that's coming up in June also. But the first one is the lung cancer one, and it is an important issue. Again, we need to get more science to sort some of these things out.
A great, fun way to get involved, learn more, donate money, and find out more.
And just
get
the
more
ALA
research.
does good work. They do really good work. They've helped sponsor research for a long time that has really helped move the ball in lung disease. Your point about lung cancer is a really important one. You know, breast cancer, there's things women can do to help protect themselves by a self-exam. The problem with lung cancer is often presents when it's too late, and you don't find small nodules. You find big nodules because they've started to cause disease, and that's when you know it. And at that point, therapy can be hard. Lung cancer therapy is starting to improve, but way behind the success for breast cancer therapy.
We have some questions. Oh, Dr. Barkman, please.
Well, and ALA goes back to when tuberculosis was an important disease in this country. And they actually went to small areas with mobile units to take x-rays to evaluate people. Because I think until we had antibacterial agents for tuberculosis, the death rate was 30%.
And still is in many parts of the world, which makes TB one of the biggest killers throughout the world.
So, yes, sorry to interrupt.
No, please. Any reporters on the line today? No reporters, but we're going to get to a few more community questions. Question from, let me see, Jacqueline wants to know, how can you truly tell the difference between allergies and other sickness? Everyone seems to be blaming their runny noses on allergies. I've even questioned it for myself since my family has been symptomatic for 6 weeks, but but she's just confused about the allergies when we go past COVID and
Well,
kids.
it's really hard.
You know,
It's always
what do you
been really
do?
hard. It's really hard, right? Because people have upper respiratory effect from the rhinovirus or the old coronavirus and all that. And the reality is, it's really hard. I have allergies. I don't know half the time if I have an allergy or if I have a cold. Right now, I do a home test for COVID. I make sure I don't have COVID. Good, I don't have COVID. So then it makes me feel better that I might have an allergy. I think itchiness of your eyes, itchy throat, lots of sneezing, and not the febrile illness are things that help distinguish, but none of those guys, and I'm going to look at my ID and my occupational medicine guys, I think it can be really hard sometimes.
Correct. Again, and you know, if cold, maybe you've been around somebody ill and then you become ill with it, as opposed to allergies, because everybody, even in a small group, has different propensity for an allergy. So you tend to stick out with that, as opposed to everybody in the house being ill. If the whole house comes down with it, it's probably a virus. Versus if it's you individually and it's the season, the viral season. I mean,
We have
the
all these
allergy
treatment
season.
algorithms, Hawkeye, and they say, well, if it's this, it's this, it's this, and sometimes it's about 50-50, which is about like a coin to tell the difference. And sometimes we get more successful. I think fever is a big game. Yeah, if you're febrile, you can have allergies, but it's really much more rare. It's almost always infection then.
Yeah, no, I agree. I think that's the bottom line. It is very confusing. Definitely take into account your history, what season it is, but you can make that hypothesis and that educated guess. But overall, Steve, just like you're saying, to truly have a diagnosis, it is difficult unless you do that diagnostic testing.
Dr. Barkman, Isaac has a question for you. Wants to know your thoughts on the hygiene hypothesis, which basically says interventions that have reduced exposures to various germs in childhood leads to greater incidence of allergies because people's immune systems have less experience and so on and so forth. But just curious your thoughts about that. Is that a thing?
Yes, the Dutch hypothesis, but actually NIOSH did some studies in farming where families grew up on farm and had multiple exposures, and there is some science to suggest that that's true, that you do need exposures to develop tolerance as opposed to allergy.
And then some of the people want to have dogs and cats at a very young age of their kids.
Right. So again, kind of like the peanut thing also.
Right.
We don't understand it. It is true, I think, the Dutch hypothesis, but does it apply to everybody? No. Can we sort out genetically who it does? But I think it is important for your immune system to have exposure, to develop antibodies against infectious agents, but develop tolerance for allergens.
And
Makes
I think
sense.
people then jumped immediately going to say, well, then we should never wear masks because you can't develop
Right.
tolerance. Or wait. This part, the priming of the immune system occurs when you're like 0 to 6 months of age.
Right.
And so, we don't mask little children unless they have leukemia, et cetera. So that doesn't apply. The second thing is remember that allergens and viral particles that are running around the air do behave differently. And as long as you have your mask off outside, you're going to get exposed to a whole bunch of allergens.
Correct.
Couple more quick questions. Linda wants to know, I had a really bad cold and in bed for a week. It wasn't COVID. Are we seeing more severe colds? Doc? Hawk.
I think anecdotally we've certainly heard that. It's difficult to tell. Certainly we knew that specific exposures to viruses were down because of masking and things, but we also know that there was also continual or constant circulation of viruses, particularly rhinoviruses, even during the masking period. And so why is that? It could be that rhinoviruses are more stable. They're easier to pick off of fomites or inanimate objects, and then you're rubbing your eyes, your nose, your mouth when your mask isn't on and things like that. So, there's just different theories out there and those anecdotes for sure. But hopefully there will be some more information about it. But overall, it really shouldn't affect too much one's individual immunity towards those viruses or those pathogens because, again, for the most part, people have been seeing these throughout their entire life. We know that you have those memory B cells and T cells that are still there to affect and help you get over those illnesses.
Last questions from Brandon. Dr. Hawkinson, can you take Paxlovit and get monoclonal antibody therapy at the same time?
No, we wouldn't recommend. And right now, I think on the Tier 1 for the NIH outpatient guidelines, it is either outpatient remdesivir or Paxlovid. The Tier 2 would be more of the monoclonal antibody just because the monoclonal antibody right now, activity against BA2 is not as predictable. But in addition, but to answer your question, we would not have you treated with both of those.
All right, let's get to some final thoughts from our guest. Dr. Barkman, please.
Well, thank you for inviting me. I think it's the time of year to discuss these issues. Again, I think, sorting out allergy and virus can be difficult. But again, if you're in bed for a week, that is not an allergy. The biggest thing we talk about is sinusitis, where you've got headaches and drainage and all. That can get tricky. And a lot of primary care is trying to sort that out, and often you get treated with antibiotics for that, even though it might be allergy from that standpoint. So I think one should protect oneself the best they can when air pollution's up. If you have lung disease, you're at risk. You should be cognizant, stay inside, or because you can't really wear protective gear, as Stites has talked about earlier. And in terms of lung cancer, come on out on May 12th and have some fun.
Are you going to be in your tuxedo?
No, I'm not. It's not black ties.
Okay.
At any rate, but thanks for the invitation today.
No, great to meet you. Great to have you. Please come back anytime. Dr. Hawkinson, your final thoughts today.
Yeah, I'll just echo what Dr. Barkman was saying. In general, we know that 80 to 85% of those coughs, colds, sinusitis infections are typically viral. So, antibiotics don't help. We have to typically wait 10 to 12 to 14 days if you're having a persistent of symptoms to be able to give those antibiotics. So we know that there are allergies now. We know that there are significant circulation of other cough and cold viruses. Overall, it's different to ascertain, but if you think you are having symptoms, I think the first thing you should do is definitely test for COVID. That way, if you need treatment, instituting that earlier is always much better.
Dr. Stites, I'm going to get your final thoughts here in just a moment after we have this conversation. So we know the dangers of smoking, but many who tried to quit smoking during the pandemic, as you can imagine, didn't have much luck. In fact, no surprise, a new study finds they smoked more. Joining us now to talk about this is Dr. Nicole Nolan, co-leader of the Cancer Prevention and Control Program with the University of Kansas Cancer Center. Doctor, good morning. Thank you so much for being with us today.
Thank you. It's nice to be here.
Good to see you. So 2 big takeaways from this study. What was a link between smoking habits and COVID-19 safety measures?
Yeah, so first let me tell you a little bit about the study. So the study was conducted by researchers at Florida Atlantic University and looked at changes in tobacco use between June and October of 2020 among 150 individuals enrolled in a lung cancer screening program. And they found that roughly 30% of smokers increased their tobacco use, 17% decreased their tobacco use, and the remainder reported no change. So among those who increased their tobacco use, they experienced greater disruptions in their daily life. So many were unable to work. They experienced worry about securing basic needs such as housing, food, and healthcare. They were uncertain about their future, and they were simply angry and frustrated with how disruptive the virus had been to their lives. In contrast, those who smoked less demonstrated healthier coping mechanisms and greater use of preventative strategies, such as social distancing, hand washing, and wearing masks.
So, doctor, there's always going to be a stress. So how do people quit smoking? What would be some of your best advice?
Well, I think the difficulty is that, so quit smoking counseling in combination with one of the 7 FDA-approved smoking cessation pharmacotherapies, which would be nicotine gum, patch, lozenge, and then the non-nicotine medications, bupropion and varenicline, are recommended as the first line for helping those who want to quit smoking. But I think what this study highlights and what many other studies highlight is that we also need to focus on other factors in an individual's life that makes quitting more difficult. So if basic needs aren't met, it's hard for individuals to really focus on that goal of quitting smoking. And so I think we need to focus on integrating social workers, psychologists, and other mental health care workers into smoking care. So connecting individuals to services like food, housing vouchers, rent assistance programs that help with their utilities, and then also mental health programming. And it's those last, that focus on social determinants that we just simply don't do within the context of quitting smoking programs.
Dr. Nolan, thank you so much for joining us, helping us to better understand the study, and certainly your advice, always valued. Thank you. Have a great day. Dr. Stites, just your comments on, final thoughts, but just your comments on that when you hear smokers smoked more during this pandemic.
Yeah, it's not a surprise.
Right?
Stress was hard, right? People
Yeah.
drank more during the pandemic. They smoked during more in the pandemic. They ate worse during the pandemic, and they didn't get as good a care. And so I think the answer of the day is stress is bad, and what we need to do is try to address the underlying causes of stress. I think we could have a whole program here on smoking and probably a show on smoking cessation, because that's a really approximately a very big deal for health. What I also think we have to learn to do is how to pivot. If you think about the Chiefs, and you all know I love football, so when Mahomes is facing a different defense, he's got to change his plan, right? They got to change up. When they don't change up, the defense wins. When they change up, they can find what works, and they move with that. I think the same thing's true for society a little bit. We're going to have to keep pivoting a lot. It's pretty clear that another wave is coming our way with the rise in the BA2 variant and with our BA2.12 variant and whatever we're going to end up calling that, the Omicron subvariant. So I think as that happens, we're going to have to pivot. Right now, masks are off and it feels really good, right? I went to church this weekend and had my mask off when it was a little less crowded at 6:30 a.m. and had it on at 10:30 a.m. when I was back for the main service. And I think what it says is that you just have to be a little thoughtful about the environment you're in, and remember that COVID is still out there. It's still the enemy, and you've got to know that when things get higher and your risk profiles grow, then you probably put the mask back on. When the numbers drop, they come off. But really what we have to recall is that we're all in this together. COVID is the second leading cause of death in the United States right now. And because of this Omicron variant, will push ahead of heart disease. That's a bad statistic. And you know what? Just like heart disease and just like cancer, it is treatable, and even more so, it's preventable if we remember to follow the simple rules of infection control, which continue to travel with you wherever you go. They continue to keep you safe. So pivot when you need to and have freedom and enjoy it when you don't.
Great to sit here with all three of you gentlemen today. Dr. Stites, here's your 10th reminder.
Thank
Mother's
God.
Day
I need that.
is just about a month away. You forgot Mrs. Stites' Easter present, but we're not going to forget Mother's Day.
It's in the mail.
Okay, so it's in the mail. Click on this QR code right here on your screen. You can email us. Email Dr. Stites great ideas to get his lovely wife. And you can share what you want for Mother's Day. We love to share that here on our show. So you can also email us at the Medical News Network at kumc.edu. Use the address right there on your screen. And thank you so much for being with us today. Great conversation. Don't forget, you can catch our shows anytime by logging onto YouTube, Facebook, and on Twitter. Everyone, have a fantastic Monday. Coming up tomorrow on the Morning Medical Update. Access to good health care is getting tougher for many. WHO is teaming up to clear a path for smaller communities in Kansas. Join me this Tuesday at 8 a.m. as we look at this new prescription for better health.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.